You give the idarucizumab, and then the serpinetag isn't the one that's FDA approved yet, but it's in the works. It's going to be the future. And then you have the factor Xa inhibitors, which is your apixaban, betrixaban, edoxaban, and rivaroxaban. You give either the more immediate acting one is going to be the 4-factor PCC, and then you have the adnexate alpha, which is more delayed than the 4-factor PCC. So know your reversal agents. Do you guys have any questions?
No.
Okay. Okay, another question. A 45-year-old female with a history of AFib, PE presents to you with a painful right hallux infected and grown toenail. There is redness, there's swelling, there's pus, and there's pain in the toe. The patient is on warfarin. What do you do?
In clinic the other day, we did one and then just silver nitrated it a lot.
Okay, good. So you just go ahead with the procedure, right? This is considered to be a minor procedure. You don't need to take the patient in for an amputation. You're not doing incision and drainage. You're not going to expect extensive bleeding. So it's a fairly minor procedure to perform. So you don't need to stop the warfarin. You don't need to bridge. You can continue the warfarin and you could just go ahead and do the nail avulsion. You don't need to bring the patient back later. Does that make sense, guys?
Yeah.
Yes.
Okay. Okay. Which of the following is or are types of primary lymphedema?
Precox and tarda.
Good. What is primary lymphedema and what's secondary lymphedema?
Primary is congenital, secondary is acquired.
Good. Yeah, so it could be congenital or hereditary. And then the acquired ones could be like the worm, the parasitic worm infection, which is lymphatic filariasis. Could be from surgical procedures, could be from trauma. So those are your secondary types of lymphedema. What's the difference between precox and tarda?
Less than or above the age of 35.
Good. So precox is less than, and tarda is going to be above the age of 35 in terms of onset of the symptoms. Okay. I kind of made this out of order, but if you guys want to take a screenshot of this, or would you prefer I send out the slides after I finish the review?
Yeah, if you can, please, son.
Okay. All right. I'll send it out. So it's good to know the time it takes for your anticoagulants to take effect. So PCC is going to be immediate. Fresh frozen plasma, not quite immediate, but it doesn't take as long as the IV vitamin K. And then there's oral vitamin K, which takes a whole day in order to take effect. So that's why you need to know 3-factor and 4-factor PCC. Okay. Which of the following is not a treatment option for lymphedema?
Revascularization.
Good. What type of condition would need a revascularization procedure?
PAD or
Arterial.
venous. Yeah.
PAD. Yeah. So did you just say venous? You're in so much trouble if you just said venous.
No, I just meant to say PAD.
Okay. Okay, good. So it's important to know revascularizations are performed in order to reestablish blood flow. So it's for PAD. Okay, you're off the bad Santa list. You're back on my good graces. Okay, you see a patient with hardening of the skin. Yeah, if I describe it as a reverse champagne bottle appearance to the leg, you can see hemosiderin deposits with this patient. What type of pathology do they have?
Lipoprotein.
Atherosclerosis.
Excellent. And what type of vascular insufficiency do they have?
Venus.
Venous. Yeah, exactly. So it's venous disease. What about this?
Varicose nostra. Some elephantiasis nostra varicose.
Yeah, so this is basically end-stage lymphedema. And like, what do you refer these um, these skin lesions? How do you call that?
Nodules.
Nodules, yeah, could be papillae, papules, could be nodules, depending on the size. But exactly. So this is lymphedema, and when you do your physical exam, what vascular symptoms would they have? So this is a dermatological presentation with the nodules. How can you evaluate their vascular? What sign are
Doppler.
Well,
Stem
yeah, you are correct. You use a Doppler for the pulses for the arterial side. What about specifically for the lymphatic?
stemmer.
Summer, yeah, exactly. Is it going to be positive or negative?
Positive.
Positive.
Positive stemmer, exactly. So how's this test performed?
Second toe.
Yeah, so you try to pinch the base of the second toe, and if you can't pinch it, it's going to be positive, negative,
If you can't pipe pinch it, it's positive.
positive, exactly. And so with lymphedema would be a positive stemmer sign. What about the edema of the leg? How do you look for that?
Check if it's pitting.
Say that again.
You check if it's pitting edema or non-pitting.
Yeah, exactly. So with end-stage lymphedema, it's going to be non-pitting because there's so much damage to the tissue, there's so much scarring that swelling isn't going to form a pit. Okay. So what's the most likely diagnosis based on what you guys just told me?
C.
Did you just say D?
C.
Oh,
C.
C. Okay, thank God. So it's C. It's lymphedema because they have a positive stemmer sign at the base of the second toe. The edema, the patient reports to you that with elevation or sleeping at night, and then with elevation of the leg, the swelling doesn't go down, and it's mostly unilateral edema of the leg and the foot. If I just say that the patient has swelling down to the ankle, and it's bilateral swelling of the lower leg down to the level of the ankle, it's a female patient, what is the most likely diagnosis?
Lipedema.
Lipedema, good. So bilateral edema only to the level of the ankle with normally presenting feet without a stemmer sign is typically lipedema. Okay, so we just talked about stemmer sign, and that concludes my review. Do you guys have any questions?
Can you go over the tracing the blood clots thing
Yeah,
for my edification?
yeah. Okay. So you need to know how to let let's say the blood clot starts at the posterior tibial vein. Now tell me how to trace it back to, let's say, the right atrium.
It'll go popliteal, femoral, or what? So deep femoral or femoral?
It
Like,
would be the deep femoral.
the deep femoral.
Then what?
Then the femoral.
Iliac.
Thanks, sir.
External iliac. So
Mhm.
you need to know that it's external iliac, it's not internal iliac. Then what?
Common iliac.
IVC. Oh, yeah, common iliac.
Well, you also have to determine the laterality, right? So it's external iliac. So let's say this is the right lower extremity. So it's the right external iliac, then what?
Then the right or the right common iliac,
Right common iliac, good. Then what?
the
IVC.
IVC,
And then what?
right atrium.
Right atrium, yeah. Okay, let's say a clot originates in the great saphenous vein in the ankle. Trace that for me. So we're starting off at the great saphenous vein in the ankle. The great saphenous vein drains into the femoral vein. How? Through what? Do you guys remember the three types of vessels? You have the superficial veins, the deep
And the
veins,
confluence?
and then, yeah, so the confluence is just basically saying that there's a perforating vein that connects the great saphenous to the femoral, right? So there's a confluence. Now, where does the clot travel to?
External iliac.
Yep. And then it basically continues on into the right atrium. Does that make sense? Did I lose you?
No, it makes sense. Dr. Lapata.
Okay. Andrew?
Yeah, yeah. The
Where
deep
did
fennel only doesn't, nothing drains into the deep fennel.
No, basically it's going to be just a femoral.
Okay. All right, yeah, then that makes sense.
Okay. This is the best representation of the venous system I could find online. I couldn't find anything better. So that's why if you have questions about it now, let's talk about it. But there's going to be a question on that on the exam, so know how to follow clot all the way back to the heart.
Will they specify laterality for the clot?
Yes. Like, I'm not going to try and trick you and say, okay, it originated in the right metatarsal vein, and then somehow it jumps to the left popliteal vein.
Can you explain the metatarsal vein that you were talking about before?
Yep, so you have metatarsal veins. You have dorsal and plantar metatarsal veins. So you have the metatarsal veins, depending on if it's the dorsal or the plantar ones, then they drain into the dorsal venous arch or the plantar arch. So it's going to give you options specifically, whether it's dorsal or plantar, depending on which metatarsal vein it's coming from. So if I say it's the dorsal metatarsal vein, you need to know that it drains into the dorsal venous arch. And then the dorsal venous arch, it's going to drain into the anterior tibial or the perineal vein, which then drains into the popliteal vein.
Can the dorsal venous arch go both medial and lateral via the marginal veins?
Yes. Yeah. So if
Then how would you know if it goes up the great saphenous pathway or up the lateral pathway like the anterior tib and common fib?
so I see your point. Let me look back at the
Are
question.
they because they're deep veins?
Will that laterality be told?
Say that again. Oh, whether it's medial or lateral. I'm not going to try and trick you. So you're not going to have like two options where it's going to be medially into the anterior tibial or laterally into the perineal. So it's going to be pretty obvious, where it's going to be traveling to. Well, let me refer back so I don't get you guys confused, because I feel like I'm confusing you with my explanation right now. Do you guys have any other questions while I'm looking this up?
The one that you said that it's going from the venous arch, like the dorsal or plantar, to anterior tibial or peroneal.
Mm-hmm.
Is there going to be a time where we're going to have to differentiate which one, or is it just like whichever one is there?
I think the way I structured it, I made it whichever one is there.
Okay, and then from there, is it going to the posterior tibial before popliteal?
Uh, so it's going to be posterior tibial to the popliteal.
Okay.
Can't open up the questions, and I can't open up on the desktop because you guys could see me sharing it. Let me see. Can I stop sharing for a minute? I'm going to stop sharing, okay? So I want to pull up the question to see how I.
Okay.
Can you guys still see the screen?
No,
No.
Okay. Are you guys lying to me?
maybe. No, or
We'd
not.
never lie to you, Dr. Lapata.
What is it?
We wouldn't lie to you.
Okay, thank you. Let me pull up the questions. Okay, I'm gonna go over the chart that I sent you guys. Do you remember the chart where I had you fill in the blanks, but I never went over it? Okay, so the way I structured the question, it's going to be obvious where it's coming from. So I'm not going to be tricking you in terms of like anterior tibial versus posterior tibial versus perineal. So you need to know the direction from, let's say, the anterior tibial to the popliteal to the iliacs to the IVC. Does that make sense?
Wait, can you say that again?
Yeah, so I'm not going to try to trick you to determine whether the clot is traveling from the anterior tibial into the posterior tibial into the perineal vein. I would be asking for the route from, let's say, anterior tibial to the popliteal, to the iliac vein, to the IVC, to the right atrium. Does that make sense? So I'm going to tell you exactly where the clot is. And then you're going to tell me the route from that vein directly up to the atrium. Or if, let's say, I have a scenario where there's, let's say, a PE identified. How did it get into the lungs from, let's say, the anterior tibial vein or the posterior tibial vein? But I'm not going to give you several options like anterior tibial vein, posterior tibial vein into the perineal vein. It's going to be a direct route. If I say any more, I'm going to give the question away.
Yeah, that makes sense. Thank you.
Okay. Okay. Do you guys have any other questions before I switch to the chart?
Yeah, I just wanted to confirm. So is it foam or alginate that's more absorbent?
So for the purposes of the exam, it's going to be foam and then alginate. And then what is the most absorbent out of them all?
Alginate.
Super absorbent.
Super absorbent, yeah.
Okay,
Does
thanks.
does that help?
Yeah.
Okay. Do you guys want to go over the chart? Or do you want me to just send it to you guys?
Am I going over it? Anybody else?
Yeah, that's
Okay,
good.
so do you have the paper with you so you can refer to it? I'll send this to you afterwards too. Okay, so you have a dry wound. What do you want to put on it? What do you want to do to the wound?
Moisturize it.
Moisture, and then your options are what?
Honey.
Honey, good. What else?
Hydrogel.
Collagen.
Saline. Not collagen. Why don't you want to put collagen for a dry wound? What can happen? So collagen gets incorporated into the wound bed, right? So if you put collagen, even if you moisturize the collagen and you add saline to it or hydrogel, it might not necessarily be enough for the wound. And then the collagen absorbs the moisture, and you already have a dry wound bed, and it forms a scab, basically overlying the wound bed. So you don't want to put collagen on the wound that's really dry. You want to add moisture to it. Does that make sense? Yes? For minimally draining wounds, what you want to do is the goal is to keep the wound bed moist. You don't want to keep it dry because that's going to kill the cells, and you don't want to add too much moisture either. So you want to add something like hydrogel to add enough moisture to maintain it. And remember, hydrogel, even though it adds moisture, it does also absorb. Then you can apply saline, like we mentioned. And saline specifically, what type of saline gauze? What do you want the gauze to do? Do you want it to stay dry or do you want it to be moist?
Wet to wet.
Wet to wet, good, exactly. And then you can apply hydrocolloid if it's a moist wound bed also, in order to help maintain the moisture. What does the hydrocolloid do? What does it do to the wound bed? So think of those little acne patches. What does it do? Because the acne, think of it as like a little blister. It helps to occlude. So it helps to maintain the moisture and encourage an even more moist wound bed environment. You can use film over minimally draining wound. If it's heavily draining, you don't want to apply hydrocolloid or film because it's gonna basically come right off the wound bed. Moderate to heavy draining wounds, we talked about absorptive dressings. So remember, super absorbent is the most absorbent. You can apply hydrofiber like Aquacel. You could apply foam or alginate. And then you can apply negative pressure therapy. What does negative pressure therapy do?
Encourages granulation.
Yeah, what does it do to the drainage?
Takes it away from the surface to prevent maceration or infection.
Yeah, exactly. So it helps to remove the exudate, the drainage. Obviously, if it continues to drain the wound without improvement or healing noted, there could be an infection underlying. So you have to really address all of the factors. You can't use negative pressure wound therapy indefinitely for a year. If there's macerated wound edges, you want to make sure you protect the edges. I'm not going to test you on this part because I didn't include it to your lecture material, but just for life, know that you want to protect the edges. You can apply zinc cream. You can use skin prep or skin protectant to the edges. You can use Vaseline also. You can use A&D ointment. And you can use other dressings like film dressings. Like when you apply the wound vac, you can apply a film to the edges to help protect that skin. Or you could use hydrocolloid also. You guys remember using hydrocolloid in the workshop and learning about hydrocolloid, knowing that it could be used with wound vac therapy to help protect the edges. If you have increased signs of inflammation, you can address the bioburden by using the iodosorb or the cadexamer iodine. You can use Medihoney because that helps to decrease the microbial load. And then you can use silver dressings. And silver is really indicated for also actively infected wounds. You could put silver alginate. You could treat with antibiotics, whether it's topical or systemic antibiotics. We didn't talk about odor control, but iodine can help. Certainly, you guys have noticed in patients that have had wound infections, if you apply betadine gauze, that helps to mask some of the malodor for actively infected wounds on the floors. And you can use something called cadexamer iodine, which also has iodine, to help control that. Another dressing option is activated charcoal. Again, you're not going to be tested on this, but this is something that you can use for life. Pain control, remember we talked about non-adherent dressings. So patients who have full sensation, their wounds, especially if they're traumatic wounds, are going to be painful. And it's going to be painful to apply a gauze and to remove that gauze at every dressing change, even if you add moisture to it with saline. So if you use a non-adherent like Adaptic or Zeroform, that helps to decrease some of their discomfort level when you're doing the dressing changes. And again, you can use topical analgesic, so you can use topical lidocaine that can also be prescribed for your patient. And you can prescribe oral medication for pain control. And you can always remember we talked about moist wound healing. You can add moisture to the wound bed to help decrease some of the pain. We talked about regenerative therapy to help increase tissue growth in terms of timers and dimers acronym. So collagen, we talked about what collagen does. It helps to create a scaffold. It helps to decrease the proteases, which are your matrix metalloproteases, so that you can have more TIMPs in balancing the chronic wounds into progression of wound healing. I talked about Regranex. So what does Regranex or Bicaplermin do? You guys know what Regranex does?
No.
No. Do you guys remember
Is it a platelet-derived growth factor?
yeah, exactly. So Regranex is made in the it's pharmacotherapeutic. It's made in a lab, and the whole point is if your wound stalls in creating granulation tissue, especially in a diabetic foot ulceration, you can apply this, and because of the platelet-derived growth factor, it's going to encourage granulation tissue formation. Because with diabetic wounds, they can be they don't have enough oxygen, they don't have enough growth factors in the wound bed. So you need to decide with the debridement, do they need added help in generating new granulation tissue? The wound might not be big enough for, let's say, a wound vac. It might be really small, but it's stalling, it's not progressing. So you can prescribe Regranex and apply that in the clinic and have the patient change the dressing at home to encourage granulation tissue formation. Then we talked about different types of grafting. So there's living allografts, and one example of that is an aplograft. So that actually has living stem cells. And when you apply the stem cells, the wound, what type of a wound bed do you want to have when you apply these type of grafts? What should the wound look like when you apply it? Are you applying it over exposed bone?
Should
No.
be
Granular? It should be granular, exactly. So a fully granulated wound bed would be an ideal wound type to apply this type of a graft. You have human amnion chorion membrane allograft. So those are also grafts that involve stem cells. but those are dehydrated tissue. So one example is an EpiFix. So you guys will be working with Dr. Iorio if you have it. He uses EpiFix for fully granular wound beds to help with epithelialization. So for anytime you're using grafts like these, where they're stem cells, you want the wound bed to have a foundation, a scaffold. It's fully granulated so that you can form skin over the granulation tissue. Then you have a dermal matrix. So this is an option like a graft jacket, and graft jacket is used over what kind of structures?
Exposed bone.
Yeah, so you could put it over exposed bone, tendon, joint, any deep exposed structures, you can put that over. You have biosynthetic matrices. So these don't involve actual living tissue. These are manufactured grafts that don't come from living organisms. So this could be like your Integra graft. I talked about ACell a little bit earlier. So these types of grafts, just like your graft jacket, can go over your bone, ligament, tendon, any deep structure. And then you have negative pressure wound therapy, which can go over your deep wounds, post-operative wounds. So let's say somebody just had an abscess, had a debridement of the abscess, and now has a defect in the wound, or if somebody had an amputation and has exposed structures, you can apply negative pressure wound therapy. You could put it over a graft to help it incorporate. Um, uh, it could be applied to a draining wound, unless it's from directly from an active infection, then you want to address the infection first. And then you have something called PRP, or platelet-rich plasma. What is that? So platelet-rich plasma, where does that come from?
The
Patient
blood.
blood.
Yeah, so it comes from the patient's blood. So you isolate their platelets, and then that is going to be injected into the wound because it has a specific growth factor. What growth factors does it have?
Platelet-derived growth factor.
Exactly, and vascular endothelial growth factor. So it has growth factors in order to help encourage what tissue to form.
Granulation.
Exactly, yeah. So you want granulation tissue. So this is great for patients that have delayed granulation tissue formation. Not typically used for exposed deep structures because it's going to take a long time for the granulation tissue to form. So you really want to use a wound vac for those. Then I talked about xenograft, which is your Kerasis graft that comes from fish skin, and that can be used for more superficial wounds that don't have deep exposed structures. And hyperbaric oxygen therapy also encourages tissue growth by encouraging granulation tissue formation. Okay, we talked about compression therapy, so I want you to remember ABI is really important before utilizing any type of compression therapy. And when would you not want to use compression therapy?
PAD.
PAD. Good. What else? Let's say the patient comes in, has swelling in the leg, redness, pain, unilateral swelling, pain, and redness. What type of condition is that?
DVT.
DVT, yeah. So you don't want to use it in an acute DVT. What else? You have a draining wound. There's erythema surrounding the wound. The wound is malodorous. What don't you want to do? an active infection, why won't you apply compression to active infection?
You can spread it.
Yeah, exactly. So you're going to see the infection deeper down into the tissue. And then acute onset of heart failure. So if your patient also isn't compliant with their water pill, you also want to take caution in applying compression because you're going to overload the heart with fluid. And then another thing that I want you to keep in mind, this is kind of inclusive of all of the material you went over this term. If you have a diabetic foot ulceration, or if you have Charcot, what would you want to do? No signs of infection, what would you apply?
Total contact cast.
Exactly. So total contact cast, you can use other offloading devices like a Cambu. You can use a wedge shoe, like a 4-foot wedge shoe. Surgical shoes alone don't really offload. You would need to use felt or foam cutout pads in conjunction with the surgical shoe. And then you can use something called a Pegasus, which is basically like an insert, and you remove it kind of looks like a puzzle, and you remove some of the pieces to help redistribute the pressure. You can offload with strict non-weight bearing, and then patients who are at risk for developing pressure ulcers of the heel, you can have them apply something called a multi-potus boot, or a Prevlon boot to help offload the pressure off of the heel. And then take into consideration what kind of mattresses they're using. So they could use air mattresses, foam mattresses. Okay, do you guys have any other questions? No? Yes? Who's on? I have 23 people here. Do you guys have any questions?
No, I don't think so.
I guess.
Okay.
I don't think so, Dr. Licata.
Okay, all right. So this concludes the review. I'll send out the sheet, but make sure you review the absorptive capability of the dressings in order from least absorptive to most absorptive. Make sure that you're familiar with the advanced wound therapies, including wound vac and the grafts and the types of grafts you want to apply and not apply, depending on the type of wound they have. And you guys can email me. I rather you actually call or text me if you have questions, because I'm not going to be checking my email as often, but reach out. Do you guys have my number?
No.
No? Okay. Let me put in the chat. Okay. I'm gonna sign off, so let me know if you guys have any other questions.
Thank you. This was very helpful.
No, thank you. Thank you, Dr. Licata.
Thank you. Thank you.
Thank you.
Thank you.
Bye.